Okay, we're ready now. So thanks for everybody taking the lunch hour to come and learn about Dravet. I know you could all be standing in line to get your Popeye's fried chicken sandwich, which is all the rage, and back out, just in case you didn't know. Came out yesterday, so go get in line. So I am going to be talking to you about Dravet syndrome and new therapies. We'll talk at the very end. You know, I know the title is other genetic epilepsies as well, and the truth is that Dravet syndrome is so far along with the amount of work being done in Dravet syndrome, and so much of this can be extrapolated to some of the other channel disorders that I think seeing what happens in Dravet syndrome will give you a good idea of what are the possibilities for many of the other rare genetic epilepsies that we deal with. Just some quick disclosures. I do receive honoraria for companies that work in this field to develop drugs. I also do consulting for some of the companies that are working on gene-based therapies for these disorders, as well as serve as a principal investigator for several different research trials of some of these meds. So what I'm going to do in the talk is I'll start just to get everybody on a nice level playing field of talking about Dravet syndrome and its typical presentation, as well as the genetic cause of the disorder. We'll talk about what is the long-standing treatments, the standard treatments of Dravet syndrome, and then really get into all of the new drugs that have been developed, and many of them just coming out in the last couple years to treat the disorder, and finally end on some of the very exciting changes that are coming for treatments that are looking beyond just treating seizures and trying to see if we can treat all of the comorbid conditions that come along with Dravet syndrome. So for any of you that have a child with Dravet syndrome, you know that this has been described in the 70s by an epileptologist named Dr. Charlotte Dravet. And it was originally called severe myoclonic epilepsy of infancy. And these were the clinical criteria that Dr. Dravet initially described. They were people that had a family history of febrile seizures. They were otherwise healthy kids. Their seizures began in the first year of life with usually either one-sided events, so just shaking on one side of the body, or generalized events. Generally, after the age of 2, they developed other kinds of seizures in the absence of fever, so episodes of myoclonus, which are just little quick muscle jerks. Their EEG was often normal at onset, which is why they were commonly diagnosed as having febrile seizures initially, and then later on the EEG changes, usually after age 1. Development is normal in the first year of life, though after the first year of life, especially when the seizures begin to increase and the EEG becomes abnormal, we start to see a slowing of the development. And then other features start to develop, other neurological signs may develop over time. And this disorder is very resistant to treatment. In 2010, the criteria were modified because at the time you collect more people with Dravet syndrome, you realize that not everybody presents with exactly how Charlotte Dravet described it initially. So the first thing we changed is that having a family history of febrile seizures is actually not that common. Maybe 15–20% of people may have a family history of febrile seizures. And the initial seizures are not always in the setting of fever. Atypical absences, which are prolonged absence seizures or absence seizures with more complex motor phenomenon, are common in these children. Photosensitivities, certain patterns can bring on seizures. MRI is normal. And the amount of cognitive delay is varied. So you can have people who are very severely affected with Dravet syndrome, and you can have children who have much less cognitive delay. So, for doctors and for parents and all providers, there are clues that should clue people in to recognize this disorder very early on in life. And the first is seizures between the age of 5 to 8 months in general. And they may or may not be associated with fever, but when they are associated with fever, or even modest hyperthermia, so things like taking a hot bath or being outside on a hot day, that should certainly stoke the idea that it might be Dravet syndrome. If this child comes in with unilateral or one-sided clonic events, one-sided shaking that alternates from side to side on different times they come in, that's definitely a clue that you may be dealing with Dravet syndrome. And then if the duration tends to be very long, so 15-minute, 30-minute long febrile seizures, these are very good clues that we're dealing with Dravet syndrome. And you have to, again, understand that while the EEG may be normal and the child is normal, those are clues that should point people to it. Now that we have programs in this country where kids up to the age of 5 can get free genetic testing, there's really not much reason that children with Dravet syndrome should be missed because that program is open to any child with a new onset seizure. After time, other seizure types will begin to develop, so generalized tonic-clonic, or what people call grand mal traditionally, myoclonic seizures, atypical absence seizures, and again, the EEG becomes abnormal. Between the age of 1 to 4, you start to see some of the slowing in the delay, so it's not necessarily that these children always lose their cognition or start to lose skills they have, though sometimes that does happen. What happens is that they just don't progress as other children their age, and so the divide between a child that is cognitively normal at their age, between them, increases as the years go by. Behavioral concerns start to arise. Any of you that have children with Dravet syndrome, things like inattention and hyperactivity are certainly difficult and common. Problems with sleep start to appear, and other comorbid conditions. As we move into adulthood, we like to feel like we have some idea of what happens, that the seizures might be less, that they are rarely as prolonged. They do develop some abnormality of the way they walk, a typical kind of crouched stance, and they may kind of shuffle. But the truth is we don't really know what Dravet syndrome looks like in adults because we don't have a lot of adults with Dravet syndrome to look at. What we have is a lot of children with Dravet syndrome. There are a lot of adults with Dravet syndrome. They just don't know they have Dravet syndrome because they weren't tested, because genetic testing wasn't around to the degree it is now when they were children. And so they are going to clinic just with bad epilepsy. And so we don't know what it really looks like in an adult. So as I said, Dravet syndrome is more than epilepsy. Epilepsy is simply the tip of the iceberg in this disorder. We have cognitive behavioral problems, sleep problems, gait and orthopedic problems, feeding and gastrointestinal problems, social problems, autism symptoms. We have autonomic disorders, and of course, sudden unexpected death in epilepsy is 15 times higher rate in people with Dravet syndrome than other people with epilepsy. And that's higher than just people with intractable epilepsy. Dravet syndrome has a very high rate of sudden unexpected death, which is why, among all these other reasons, it's incredibly important we find a way to cure the disorder. So as I said, this is really kind of the change, and what's associated with what? Hard to know, right? If you control the seizures in a child with Dravet syndrome, will they do better cognitively? Absolutely. If you control seizures in a child with Dravet syndrome, will they be cognitively normal? Absolutely not, because the channel disorder itself is part of the problem. So it's not just the seizures. There's something wrong with having the SCNA channel mutated results in some of the comorbid problems we see. So as I just said, the reason for Dravet syndrome in the majority of people is a mutation in a gene called SCN1A. So we all have 2 copies of SCN1A, and that gene encodes a sodium channel. And that sodium channel hangs out in a neuron in our brain that is in charge of inhibition. So when you deal with seizures, you have 2 systems to deal with. You have an excitatory system that makes a lot of electricity, and you have an inhibitory system that basically slows electricity down. And when the inhibitory system doesn't work, there's a lot more electricity, and that's really the problem in Dravet syndrome, is that the inhibitory neurons have this sodium channel that's malfunctioning, and it doesn't work normally. 90 to 95% of these mutations are de novo, meaning they were not inherited from a family member, and the majority of them are sequencing mutation, which means there's just one piece of the code that's slightly wrong, one amino acid that's turned a different way, and it's a different one than it should be, and it creates this problem. So as I said, you have 2 copies. Each of them will produce this sodium channel. If one of them doesn't work, it doesn't produce enough normal sodium channel to not have usually some form of epilepsy. And it's a wide spectrum, but Dravet syndrome being the most common one we talk about. So let's start talking about treatment of Dravet syndrome. And when we talk about that, first I'm going to start on the easy stuff. So the easy stuff are things that anybody can do. All right, so the first and always our goal is to control seizures as best we can. Understanding seizure freedom is very difficult, and in the past I would say seizure freedom is just not likely, but I would say now that seizure freedom stands a decent chance. So what we want to do is we control seizures, we want to avoid aggravators, and we want to be prepared to deal with status epilepticus, which is very common. Our ultimate goals, and we'll talk as we go through here, is not just seizure freedom, but getting rid of all the other comorbid conditions that come along with this disorder. So what are the traditional mainstays of treatment? So the traditional mainstays of treatment of Dravet, up until recently, have been expert opinion, basically. So drugs that people that treat a lot of Dravet syndrome said, yeah, I have some good luck with that, that's what I want to use. The only drug that had a trial that showed it worked in Dravet syndrome up until last year was a drug called stiripentol, which the brand name in the United States is Diacomet. This was a drug that it works on GABA channels. So GABA channels are those inhibitory channels, and it allows it to stay open longer. It also interacts with clobazam, another common medicine we use in Dravet syndrome, and actually elevates clobazam levels. It had a study in Europe comparing children with Dravet syndrome that were using the drug while also taking valproate and clobazam to children who had placebo. And what they showed is that there was a 69% reduction of seizures in the children taking stiripentol versus only a 7% increase in seizures in those that took the placebo. So the responder rate, which was those people who had more than 50% reduction in their seizures, was between 67 and 71% in these studies, which is quite impressive, actually, for a drug. I mean, if you've talked to your doctor about drugs over time, you know that the majority of anti-epileptic drug studies end about the same way. 50% of people get about a 50% reduction in their seizures, and it's always the same. So when you see a drug that does better than that, it's always exciting. Common side effects of this drug were anorexia, weight loss, sleepiness, and sedation. So this drug was not easy to get before. Some of you may have been able to get it. We would import it from Europe and use it. But now it is available in the United States, and it's indicated to be used in children over the age of 2 who are also on clobazam, which is brand name Onfi. Other mainstays of treatment in the past have been valproic acid, which is brand name Depakote, what you might know it as. There are no studies, there are no blinded placebo-controlled studies of valproic acid to show it works in this disorder. It's just that's expert opinion, with the 50% seizure reduction rate reported somewhere between 20 and 50%. And then clobazam. Clobazam also did not have a study in Dravet syndrome. Clobazam tried to have a study in Dravet syndrome, but by the time they tried to have their study, everyone was already on clobazam, so it was impossible to do the study because everyone was already on the medicine. Other drugs that you may hear people talk about are other what we call second-line therapies, levetiracetam, topiramate and zonisamide people use. I do use it sometimes. Both of those drugs decrease your ability to sweat and can result in overheating, which is already a trigger for children with Dravet, so I try to avoid it. Bromides is something some of you may have seen, and then perampanel was one of the newer drugs that some people have used. Other things like dietary therapy with a ketogenic diet. Some people have used vagal nerve stimulation. As you can see, the responder rates, and these responder rates are reported, they're all about 50%, and these are all retrospective studies. So the important thing, actually, we're doing a cure session tomorrow on clinical trials, and so you can come and kind of get a feel for why is it important the way a trial is designed. A retrospective study that's open label, all these people are on therapy, so they know they're on therapy. So when they report us how they're doing, they know what they're getting, so there's already an inherent bias to whether the treatment might be successful or not, which is why placebo-controlled trials are very important. So the other easy thing people can do is just avoid the aggravators. Dravet syndrome is aggravated by drugs that work on sodium channels, and lots of anti-epileptic medications work on sodium channels. So you avoid things like lamotrigine and carbamazepine and phenytoin. And when I say avoid, I mean you avoid them as a daily medication. Now, in an emergent situation in a child that's in status epilepticus, it is okay to use phenytoin if you need to, or fosphenytoin, because oftentimes it will stop the seizures, but it's not an ideal long-term therapy. You want to avoid overheating, so wearing things like cooling vests and having a fan and a mister when you're out on a hot day are things you can do. Taking breaks in the shade and staying hydrated are all important. And avoiding the triggers if your child has identified triggers like photosensitivity or fatigue as best you can. I know it's difficult. And then finally, have a seizure rescue plan. This is an important thing that should take place. For basically anyone that has epilepsy should have a seizure rescue plan, but very important for children with Dravet syndrome to have one in place, especially if you live in a place that is not familiar with Dravet syndrome and or not prepared for Dravet syndrome. So I'm from Texas, and I have a very large state with a lot of empty space and nothing but cows and oil. So we have to have plans for these people because they live hours from us, and they may have a very small EMS service that's there to take care of them. So they have a very detailed plan that when you get called by this family, they've already given this drug and this drug. When you arrive, if they're still seizing, you give this drug. And if this time they're still seizing, you give this drug. And then you give this drug. And you better be prepared that you may have to intubate this child. And you can call me anytime you want to so that I can help you through with this. And please do not stray from my plan that is clearly written for you right here. And many times they like to stray. And then we have a conversation, and generally it goes fine from there. It only takes the kid coming in their ER a couple times for them to realize they want to follow the plan. There are lots of different studies have many different stages. Okay, and again, we'll talk about this tomorrow in more detail. But these are the basic stages of research trials for drugs. And so as I go through them, I'll kind of try to highlight where these drugs are in this process. So phase 4 is a drug that's already been out. It's on the market. Basically, we're looking at other populations that might not have been studied in the primary, or we're looking at the long-term safety of the study. Phase 3 are those studies that most people are used to participating in. This is where we've seen with a smaller study, a phase 2 study, that the drug seems to have an effect and seems to be safe. Now we want to study in a very large population to make sure those results in a small population are true. Again, phase 2 is just really trying to get that initial signal that this is a useful drug. Phase 1 is testing it in healthy volunteers, oftentimes just to make sure it's safe and to get an idea of what dose can you give without causing problems. And then the preclinical piece is when we're using lab studies, animals, to get an idea of safety and how the drug might work. So we'll start at the top with drugs that are out there and ready to be used. So Epidiolex, which is CBD, cannabidiol, was approved in 2018. And it was approved with several studies. The first one is a double-blind, placebo-controlled trial in children with Dravet syndrome. So I'll just stop right there and kind of go over why that's important. So double-blind means that when you're in the trial, I don't know what drug you're getting and you don't know what drug you're getting. That eliminates the bias of me wanting the drug to work, and it eliminates the bias of you wanting the drug to work because I don't know what you're on. Placebo-controlled means that some of you are getting the actual drug and some of you are getting a placebo that has absolutely no effect. And again, that's another way to eliminate the bias and see what is the true effect of the drug when used. This was a large trial, had 120 patients, all children, less than 18 with Dravet syndrome, who had at least 4 seizures a month. And in this trial, they were treated with Epidiolex 20 milligrams per kilogram, given twice a day, versus a placebo. Basically, we do a baseline phase, which is about a month in general, where we don't do anything to treatment. Everything stays the same, and all they do is count seizures so that we know how many seizures does this person have at a baseline. Then we enter the actual trial state where you're randomized, and you get on one of the choices, placebo or the active drug, and we again just count seizures for the next however long it is, 14, 16 weeks, depends on the trial in general. And so we count those seizures over all that time, and then after that time, you roll over into an open label where everyone in the trial gets to get on the actual medication. So in this first study, what they showed were that children that were in the CBD group had an average of 12 seizures a month, which was reduced to a little less than 6, so a 39% average reduction versus the placebo group, which had a 13% reduction in their seizures. So statistically, that was significant. So shows that CBD did make a difference. The amount of people who had more than 50% reduction in their seizures was 43% versus 27%. And importantly, the number of people that were seizure-free were 3 in the CBD group out of 120 versus none in the placebo group. Beyond seizure freedom, the scale called the Caregiver Global Impression of Change, which is basically a caregiver saying, how do I think my kid's doing overall? It's more than just seizures. More people in the CBD group felt their child had improved versus the placebo group. And so that, again, gives you an idea that maybe there's something more than just seizure control that they were feeling that made their child better. Adverse effects, it's important when we talk about CBD especially, no drug is without adverse effects, and this drug has adverse effects too. So 93% of people in the CBD group versus 75% in the placebo group report adverse effects. This is another reason why placebo groups are important, because in order to get a feel for what is just being a child, do you really have more fever in the treatment group, or is fever just a common thing that happens in kids? Because we will ask you about every side effect to see what's going on during the trial. So what they saw is that in general, diarrhea was more common in people that were on CBD. You certainly could have fatigue or sleepiness more commonly on CBD. That was most often in people who were also on clobazam, because Epidiolex increases the levels of clobazam, which increases your sleepiness. We also saw some more fever, actually, in the CBD group, and also had some elevation of liver enzymes. So elevation of liver enzymes occurs in a relatively small proportion. The studies range from 7% of the people. Some of the studies with much higher doses got even up to 25%. And it's almost always in people who are on valproic acid as well. It does happen without being on valproic acid, but it most often happens when on it. And reduction of the CBD or reduction of the valproic acid, or in some cases doing absolutely nothing, seems to make the liver enzymes come back to where they should be. So there's a second study in Dravet syndrome. Now this one was a dose ranging study, so it looked at people who were on 10 milligrams versus 20 milligrams versus placebo. And basically what you can see from what, whoops, that's not what I wanted to hit. What you can see from this is that, so this was the 10 group and this is the 20 group, and as you can see they're quite similar. And so there's not actually a huge difference in seizure reduction in the two groups. There are some people that as you go up to 20, they get even better and may get 75% seizure freedom or even more. But in general, the two groups are quite similar. So that's why the recommendation is to go to 10 milligrams per kilo if they're still having seizures and it's well tolerated. You can push the drug to a higher dose and you may get a little bit better. There were some other cannabinoids that were studied at one time. So there was a company called Encoded Therapeutics that makes synthetic CBD and was planning a study for Dravet syndrome, and then they later withdrew their study. They started some other studies, and then they got indicted by the government and went bankrupt. So I don't know if they're still around, but they're in bankruptcy now, so I don't know if they're going to plan to do this or if other companies are going to buy this and try to move forward with it. So the next drug is fenfluramine. So fenfluramine is a drug that used to be part of a weight loss pill called Fen-Phen. So any of you that are as old as me remember Fen-Phen. And Fen-Phen was taken off the market because while it caused weight loss, it also caused thickening of cardiac valves and pulmonary hypertension. So it was removed from the market. And it contained two products, fenfluramine and phentermine. It was unclear which of those two drugs actually caused the problem or if it was a dose problem because they used very high doses and that's how they kind of induced the weight loss phenomenon. So somebody in Belgium thought it was a good idea to take fenfluramine and use it in Dravet syndrome. And I'm not sure the thought process, but it was ingenious, whoever did it, because they found another drug that we can use. So this drug has gone through a double-blind placebo-controlled trial as well, 119 patients, again with Dravet syndrome, using placebo versus low-dose versus high-dose fenfluramine. Same kind of setup, basically, baseline period and then the testing period. And what we found is that the average seizure reduction in the high-dose group was 64% reduction of seizures versus the placebo, and in the low-dose group there was a 34% reduction. If you look at some of the other features they looked at, if you look at the number of people who had more than 50% reduction in seizures, 70% of people in the trial had more than 50% reduction of seizures. If you look at the longest seizure-free time, the seizure-free time was longer in the high-dose group, so almost 21 days versus the placebo, which was 9 days. And so this has, these are also very exciting results. This drug has been submitted to the FDA and is currently under review for approval. As far as adverse effects go, there were no significant cardiac adverse effects in these trials. So at the doses that we were using in these trials, we did not see significant changes in cardiac function. As far as what side effects we did see, again, you see some kind of common things that show up. Diarrhea, again, shows up more commonly here. Upper respiratory infection showed up in one group, the 0.2 milligram group, at a big difference, yet no one in the 0.8 milligram group, so that probably wasn't actually an adverse side effect. Some sleepiness, not really a lot. Most important things we see are decreased appetite, which is not surprising because it was a weight loss drug. Rarely is it associated with significant weight loss, but in some cases there is enough weight loss that it can be a problem. This company also studied fenfluramine in the setting of stiripentol because many people were going to be on stiripentol, so they wanted to see what happened. And basically the results were very similar. So people who were on stiripentol and fenfluramine had an average 63% reduction in their seizures versus, as you can see, almost just 1% change in the placebo group. So a very significant difference in seizure control. Now there is a new drug that has just started phase 2-3 trials. It's called soticlestat, or OV935 is the name it's been given. And this is a drug with a novel mechanism of action. So it works on a cholesterol enzyme in the brain. And basically this cholesterol enzyme converts one type of cholesterol into another type of cholesterol that stimulates the glutamate system. And the glutamate system is the excitatory system. And so the idea here is that you can decrease this cholesterol that stimulates the excitatory side, then you will decrease the electricity, if you will, and hopefully decrease seizures. So they currently have a trial open for patients with Dravet syndrome and LGS, Lennox-Gastaut syndrome. What we have right now are just results from their early trial. Their early trial was very small. There were only like 12 or 16 people in this trial. They had a variety of different epilepsies, but many of them had Dravet and Lennox-Gastaut. And basically what they did is over the period of time, this was open label, so all these people knew they were getting the drug, and the people that had a good response basically could continue in the trial. So what this has done is it has narrowed it down to the people who do best with this drug. So when you look at these results where it tells you that the median seizure reduction was 84% and 90% at these long term, that's very good, but that was 84% and 90% for a subsection of the group, right? So this was 10 out of, like I said, I think it was maybe 16 or so. So it's a good result. I just wanted to caution people that those numbers look really high, but we're talking about the people who we selected to do best. Adverse effects: abdominal pain, fever. Some people had some thickening of their respiratory walls, and as a result, more congestion. No serious adverse effects. So serious adverse effects are things that end you up in the hospital, cause new medical problems, death, those kinds of things. So next, I'm going to get into drugs that are in phase 2, kind of early stages. And these next 3 drugs are all drugs that have been discovered through the Zebrafish model. So I'll talk a little bit about the Zebrafish model for a bit, just because I find it fascinating that anyone ever thought to do this. But when we study drugs in animals, we often use mice. And the thing about mice is they're a decent size. And if you want to study drugs, you're going to need a lot of mice. And mice take up a lot of space, and they eat a lot of food, and they cost money to take care of them. And you take mice, and you give them, you basically genetically modify them to have Dravet syndrome, and that's how you study drugs. Well, somebody thought it was a good idea to maybe study it in some other animals that are much easier to deal with. So zebrafish are about an inch long, and zebrafish can also be genetically modified to have SCN1A mutations. And so what they do is you can have zebrafish, and they can live in a little petri dish that's like about that big, and they just swim around in their petri dish. And if they have Dravet syndrome, they don't, or if they have seizures, they don't swim normally. So a zebrafish should just kind of swim around in a circle. And if they have seizures, they swim all over. That's how you know that the fish is having seizures. And it's been proven that they're having seizures by someone who took a very, very small EEG and put it down into the brain. I'm not kidding you. They put a very small EEG down into a zebrafish brain and showed that, yes, this is in fact a seizure, and that's how you do it. So what they do is they set up this, they got this lab with thousands of zebrafish that don't take up that much space, and little cameras over each petri dish watching the way they swim, okay? And so that's what these little things show. This shows, like this one's having seizures, this one's doing okay, this one's having seizures, this one's doing okay. So these cameras watch these fish. Now the other good thing about zebrafish is that in their first weeks of life, that their body absorbs whatever's in the water around them. And so what you do is you just take whatever drug you want and you just put it in the water, and you see what happens. And so Scott Baraban in his lab here in California takes this approach, and they took basically 3,500 drugs that were already on the market and just put them in the water to try to see maybe some of these drugs that we already have available might work. And so they found 3. The first is clemizole. Clemizole is an antihistamine from the 1950s, no longer out on the market or available, and it works via a serotonin mechanism, which is a mechanism of action similar to fenfluramine. And again, they showed that when they put this drug in the water, seizures seem to improve. The next drug is one called lorcaserin. It's actually on the market as a weight loss drug called Belviq. Again, similar serotonin mechanism of action. Again, decreased seizures in the zebrafish model. This is just another example of how it works. It's not all showing here, but basically these are the fish before they put anything in the water. Then after about 30 minutes, you start to see that the pattern with the drug in the water, normalizes, and then you can't see the bottom, but basically the bottom, it all looks like they're swimming normally, and their seizures have been better controlled. Lorcaserin was actually looked at in an open label trial, so these people know they're on the drug. It was 36 patients. They had a lot of different seizure or epilepsy syndromes, but Dravet was common. And so in real life, when we tried it, basically about a 50% reduction in seizures in the group over an average of about 11 months of treatment, with side effects as we would expect: decreased appetite, some weight loss, and decreased attentiveness. Trazadone is another drug that's already FDA approved. It's out there for the treatment of anxiety and depression. Again, similar serotonin mechanism of action, shown to be at least effective in the Zebrafish model, so another potential option for us to consider for Dravet syndrome. There's a company called Neuro Psychotherapeutic's that's working on a GABA modulator. So again, GABA is that inhibitory modulator. GABA is the channel where benzodiazepines like Ativan and diazepam, Versed, midazolam work. So this drug is targeting a subtype of the GABA channel with the idea that certain subtypes of the channel seem to work better for seizure control. So if you can get right at that piece, you can get better seizure control and less sedation. And so that's what they're working on. This may enter early clinical trials sometime next year, at least according to their website. Supernus is a company that acquired a drug called Huperzine, which is an anticholinesterase inhibitor. Again, it's just another mechanism of action that we don't have seizure drugs with this particular mechanism of action. In some studies of mice with SCN1A, it showed anti-epileptic activity, but in the zebrafish model, it didn't seem to do anything. So they're currently looking at it with focal seizures in adults, and whether or not they actually plan to look at it in Dravet syndrome, I don't know. I would guess maybe not, given the number of drugs that are out there for Dravet syndrome right now. They may not pursue Dravet syndrome anymore. So those are all exciting, right? I mean, again, 10 years ago, we had some expert opinion, and I could have told you about that over about 5 minutes, and now we have an hour-long talk about all the things that are out there. So that's very exciting. Those drugs are all good. They are good choices for Dravet syndrome, but they are not specific to Dravet syndrome. There's no reason to believe necessarily now they're any more special for Dravet as any other epilepsy type. It just happens that's the population we've chosen to study. So what we want to get at is, those drugs help control seizures, and that's great. But our next step is, how do we control seizures and get rid of all the stuff that comes with it? Or how do we prevent maybe the stuff from ever happening to start with? So that's where we get into what's called disease targeting treatments of Dravet syndrome. So this is specific to the actual genetic mechanism and how can we fix it. So there's a drug called Atalurin. Atalurin is a drug that has been approved for treatment of muscular dystrophy. And the way this drug works is that, so basically you have your DNA, and your DNA gets turned into RNA. And what happens in the body is your little ribosome runs down the RNA and it reads the code, and as it reads the code, it's like knitting, and it knits out a protein that is SCN1A. The problem in Dravet syndrome is that many people have nonsense mutations. So along the code that tells you what to do, the code gets messed up and it says stop. And so instead of running all the way down to the end and getting this very nice protein, it gets here and it says stop. So it quits making the protein. It says I'm done. But the protein's non-functional because you didn't finish making it. So Atalurin aims to jump over that. So what it does is Atalurin enables the ribosome to go down, and when it gets to the stop codon, jump over the stop codon and go finish encoding the rest of the protein. So while the protein won't be completely normal, it is a lot better than the one it was going to get because it used most of the code to knit the whole thing, right? So there is a trial currently at NYU at Dr. Davinsky looking at this, where they take Atalurin versus placebo for 12 weeks. Then they have a period of time where they stop the medicine completely, and then the groups reverse so they compare how they do for seizure frequency, adverse effects, and then they're also looking at change in cognition and quality of life. The next treatment is something called antisense oligonucleotides. So antisense oligonucleotides are basically pieces of genetic material that work, again, on the RNA. So the messenger RNA is basically the code that was read from the DNA, and then the ribosome needs to go down that and make the SCN1A channel. Much RNA comes with little pieces of information in it already that tell what should happen to it. So you have your good SCN1A and your bad SCN1A gene, and they're both throwing out this messenger RNA that's being made into proteins. And in both of them, they may have codes that say, let this messenger RNA get read and work, and many of them will have a piece of code that says, just destroy this. And it's just because they only need so much SCN1A, and so these little codes are there just to say, get rid of this messenger RNA. So good messenger RNA gets thrown out. Even though it's functional, it's no good, and they throw it out. So the idea is, how do you stop the good from getting thrown out? How do we keep it? So messenger RNA needs to be single-stranded in order for the ribosome to read it. So what an antisense oligonucleotide is a little piece of information that goes and kind of connects itself to the messenger RNA and makes it double-stranded. And once it's double-stranded, it can't read that piece that says, get rid of it. And so it doesn't. And so it just reads the good stuff and puts out the good version. So there's a company called Stoke Therapeutics that many of you have probably heard of, who have completed a lot of preclinical work in something they call targeted augmentation of nuclear gene output, or TANGO. And so basically they have identified these pieces of messenger RNA that tell it to get rid of good copies, and created an antisense oligonucleotide that will go and bind to that area and basically turn that off, allowing more good SCN1A to be transcribed. So here is my incredibly simple graphical explanation of antisense oligonucleotides, okay? So here's your good SCN1A gene and your bad SCN1A gene, and they're both going to make messenger RNA. And they're going to have these little decay exons in them. Some of them will, and decay exons is what says, get rid of this. And then they're going to have some that don't have decay exons, and the good stuff's going to get made. So the antisense oligonucleotide is going to come and attach and basically eliminate this ability for the decay axon to work. So when you don't have an antisense oligonucleotide there, you're only going to get 50% of good stuff, and you get some 50% of bad stuff, and that's just not enough. You're going to have Dravet syndrome. So when you have the antisense oligonucleotide that connects there and gets rid of that decay axon, then you'll be able to make 100% of good stuff. You'll also make 100% of bad stuff. But I don't care if you make 100% of bad stuff, because bad stuff doesn't work, so it really doesn't matter. We just want more of the good stuff, right? We don't have, to our knowledge, a problem with having too much SCN1A. Now, this is something that we have to be cognizant of, because there are disorders where if you have too much of something, that's bad too. So the best example is Rett syndrome. Rett syndrome is a disorder where if you have not enough MECP2 is the protein, you will have Rett syndrome. Well, the opposite is true. If you have MECP2 duplication syndrome and have too much of it, you also can develop a significant developmental epileptic encephalopathy. So this is what they have in the mice, and this is pretty exciting stuff. So basically what they have shown is that if they give the antisense oligonucleotide, they can increase the amount of SCN1A up to the level that you see in a normal, healthy mouse that has completely normal SCN1A. Not only can they make more messenger RNA, which is important, but they also show that they make more of the protein. That's the other important thing. It's great to have the messenger RNA, but if it's not being read and made into the protein that works, it's not going to do its job. What's more exciting is that mice with Dravet syndrome die of SUDEP within weeks in general. And so this looked at the survival of these mice. And so these are the mice that were treated with the placebo. So they were not treated with the antisense oligonucleotides. As you can see, many of them died of SUDEP, as we would expect. These are the ones that were treated with antisense oligonucleotides, and they didn't die. They survived. Nearly 100% of the mice survived as a result of this treatment. So that's the first signal that it's going to do something hopefully beyond just seizure control. Now we're addressing SUDEP. Next, can we address behavior in mice and sleep in mice? Those are a little bit harder to kind of characterize in the mouse, but there are some early signs that some of these other comorbidities are improved as well. Stoke currently has a natural history trial going on, so any of you that have children with Dravet may be asked if you would participate in this. The reason this is important is because in order for us to show that the drug works, we have to be able to show it actually alters something. So not just seizures, but does it alter the course of the disease? Well, the problem is we don't necessarily well understand the course of the disease, like how everything relates to each other. So in a natural history study, we're basically just following kids with Dravet syndrome for 2 years and looking at their cognition, their seizure frequency, their other comorbidities to get an idea of how they change. So when we do the trial, we can see if we actually alter that course. The first interventional trials are expected to occur in 2020. So this will be a drug given by an intrathecal mechanism. So it'll be given through a spinal tap, that's how the drug will get into the system. There is another company that was looking at ASOs called Ecohealth. This again worked a similar way. It looked at a gene that basically repressed normal SCN1A and turned it off. It's unclear if this company is still going to pursue their treatment at this point. At least their website doesn't give any additional information of whether they care to do any more. There are some potential disadvantages to antisense oligonucleotide. One is that it may lack some specificity to targeted cells. So what would be ideal is to take the treatment right to where it needs to be, go right to the neurons that have the problem. We don't need to go everywhere. We just need it to go to those places. ASOs can have rapid clearance, so the body can break them down, which means you may need repeated treatments for it to work. But those seem to be problems that are surmountable. So I think they'll get over that. The other way to do this genetically is viral-mediated therapy. So viral-mediated therapy, again, in my very simplistic way to think of it, there are viruses that can go where you need them to go, right? There are some viruses that give you a respiratory problem because they like to hang out in your lungs. That's where they go. Well, we can take viruses and train them to go elsewhere too. So we can train them to go exactly to the neuron we'd like it to go to in your brain, connect, and drop off its payload. Viruses are good at that. You give them, they'll go where they need to go, they attach to the cell, and they insert the information that they have. That's what makes you sick. Well, it can also make you well, because we can take the virus and we can put in the virus SCN1A material to go in and help. So the SCN1A gene is far too large to go inside of a virus. So how do you address this? One approach is to take the SCN1A gene and break it in half, and send half in a virus and half in another virus, and then take it back out and somehow put it together. I don't know how people figure out how to do these things, but there is a pilot study that has shown this concept can work. They've also developed some larger viruses, so viruses that can carry more information. And then the way that's most advanced right now is by a company called Encoded Therapeutics. Basically, what Encoded does is a little bit similar to the ASO approach. Basically, you send in information in the gene that attaches to the piece of DNA that controls how much of the normal gene is basically encoded to make protein, and it basically upregulates and makes sure that more of the good stuff gets made and less of the bad stuff, so that you have more good SCN1A. So the advantages of this are that this can go straight to the inhibitory neuron where the problem is, attach and drop off the information where it needs to be dropped off. So other advantages is this is very likely a single treatment, a once-in-a-lifetime treatment that will be necessary. The disadvantages is that probably the way that it's going to be given is intraventricularly, so a surgical procedure to put the information directly into the ventricles in the brain and put it there. Obviously, these treatments are very exciting, and the idea would be the sooner we can get these treatments to people, the sooner we could hopefully prevent Dravet syndrome from progressing. What we have to do first is identify how soon you can do it. You know, you have a kid with febrile seizures who has SCN1A. At 6 months, you don't know all the time that kid's going to develop Dravet syndrome. They could have genetic epilepsy with febrile seizures plus, which is a more benign epilepsy syndrome. And so that's another reason natural history is important, to try to understand how can we identify exactly who the targets are so that we can get the treatment to people as soon as possible. There are a few other drugs out there that are looking at just modulators of the channel. So again, these are specific. So these are not gene-based treatments, but these are specific to SCN1A because these are drugs that will work just at the SCN1A channel. So Lundbeck has a drug that they're looking at. The Fleur Institute published a paper last year about a protein they discovered in spider venom that binds to this receptor that they were looking at. And this is where some of the other genetic epilepsies come in. So the good news is for the other genetic epilepsies is that Dravet syndrome has been worn down by lots of companies that are trying to investigate it. So they're at least looking for some other populations now, and they're moving on to some other things. So SCN8A has a company that is looking at a modulator of their sodium channel. SCN2A has a company that's been looking at some stuff. And many of these things that have been done in Dravet syndrome, there's no reason to believe we couldn't do the same thing in these other genetic epilepsies. So once you show it works, you just figure out, you create new genetic material for SCN8A and SCN2A. So to conclude, right on time, that standard of care for Dravet syndrome has long been valproate, clobazam, stiripentol, again, based on expert opinion. And pharmacologic and non-pharmacologic treatments can be used in seizure. Action plans are incredibly important. In 2018, we began to see the first drugs specifically approved for this syndrome, and there are multiple other compounds that are now being investigated. And the most exciting to me personally are the new gene therapies, which I think are really going to change the course of this disease and potentially get to a point where we're actually going to cure an epilepsy by altering the genetics that were injured in the first place. The end goal will forever be not just seizure reduction, but resolution of all or prevention of all the comorbid problems that come along with having these genetic epilepsies. So I will end with this. This is Cook Children's Hospital in the lovely city of Fort Worth, who very kindly every November helps me out and turns purple to recognize Epilepsy Awareness Month throughout the month. So we certainly appreciate our city and our hospital for appreciating what we do and helping raise awareness for these disorders. So thank you very much. Yes?
For some of the newer gene therapies, is it more place going to be doing? Like, we want to get our kids going on them or try to get our kids in some of these studies.
Yeah, so the sites for these studies haven't been picked yet. Multiple places are in the process of being looked at. So we've gone through the process to be considered a site. What's important to know about these studies is that they'll be like other drug studies. They'll have inclusion and exclusion criteria as far as how many seizures you need to have. There's actually inclusion and exclusion on exactly what types of gene mutations you can have. They are going to be very small studies. So this initial study is really just looking at safety and looking to make sure that there's some sign that it works. So there's only going to be like 30-something patients in the study. So very small. And then once that goes over, then there may be a bigger study that follows that. So it's, like I said, the Stoke is the furthest along, and that's probably going to be sometime maybe in the first half of next year.
Do they know where that's going to be at?
No, same thing. They're still looking at all the sites and trying to figure out where they want to go. There's a lot of process that goes into doing this, a lot of coordination, and so they got to make sure they have sites that are going to be able to do all of the stuff that's needed for the protocol. I'll go with purple, then I'll go to you next, ma'am. Purple, that's like everybody. I'm sorry, you. So they can, because it's not about the mutation per se. It's about grabbing that piece of information that works. And so if you have a deletion, you could delete the entire gene, and you only have one copy, as long as you can get that ASO onto that copy and say, stop destroying good versions of this, you'll still have more SCN1A. Yes, ma'am. Right. So there's two problems with that. So first problem is no, they don't go past 18. And the reasons for that are one, because there's not a lot of adult centers that are really adult centers for Dravet, right? So it's hard to get a site up for that, and then to get a pediatric center to take adult patients into their trials is difficult. Really, I don't know what the upper age limits are going to be on these new drugs I talked about at the end. They're probably going to stick to pediatric populations initially. Zogenix for fenfluramine does have an expanded access program to access the drug for now until it is FDA approved. And that protocol does allow adults to get it if you can find a place that's doing it. There's not a lot of places that do it, and then that take adults. Yes, ma'am.
You mentioned that there's some companies working on SCN2A.
So they're basically working on, I can't recall the names of them offhand, but they're working on channel modulators is what I've seen primarily. specific to the SCN2A channel. But again, I think these other things could be extrapolated to SCN2A. Like, you know, you got to take one of them and show it works, and then it seems you can just start to change the genetics and make just a different version. I'm sure they'll have to go through all, you know, they have to go through the same long process of study, unfortunately. But at least the basic preclinical stuff will have been laid. Okay. Well, thank you all.